Three types of metrics here. The quality metrics linked to gain sharing are those which the principal accountable, the PAPs, will need to meet a certain level in order to be eligible for gain sharing. Most of the episodes have that to make sure that there is, a bar for quality care, even if they're along with kind of rewards for cost effectiveness. And then the reporting and utilization metrics are really are there to make sure that providers have data transparency into what's happening with their population. They're not linked to eligibility for gain sharing or anything like that. They are provided on the reports that are given to the principal accountable providers, so that for the 30-day readmission rate is not listed here. It will be one of those as well. So it's not included. The 30-day rate is not included in the cost of the episode. It's only a 7-day rate, but a neonatal facility and a neonatologist will be able to look at their report to also just understand in the 30-day rate how many of their babies are coming back to the hospital. It's information back to the providers. So there are three gain sharing metrics: BPD, the BPD rate, hearing and metabolic screening rate, and the 7-day follow-up rate. And the BPD rate, based on input from our clinical advisors, there are some codes for that, but this one is going to be a portal metric, which is entering into an online portal defined as oxygen requirement for the neonate at greater than 36 weeks. Most of the other two gain sharing metrics are claims-based. The only one you'll see, the metabolic screening rate, we're still kind of combing through some of the claims data to determine if we can find and determine the right claim for that, or if there needs to be some portal entry for that. Let me just walk through the additional ones here on the page, and then I'll pause for a question. There are three reporting metrics: in-hospital mortality rate, rate of infection, which I think the definition we're trying to work out, but likely will be consistent with VAUGN, the Vermont Oxford Network, and NEC stages 2 and 3. And you'll see a number of the utilization metrics that are listed below as well. So I see a question here in the back.
Whit, is this 7-day that the parents show up, or 7-day that the appointment has been made?
Yeah. Well, a couple of things. One, the data, if you turn to page 29, you'll see comparative numbers.
We set up appointments within 72 hours for our NICU grads. All of them are seen by their PCP within 72 hours.
Okay.
But they have to comply. And
Sure.
When I'm out in the hallway and I'm getting the third-hand smoke, and I go in and their teeth are missing, and the social worker, and it's a war zone, it's a 29.
We're not expecting 100%.
And they have transportation issues, and you have
Right.
to wait till the afternoon for grandma to show up with a beat-up car to bring them home. It's an
Sure.
issue.
We understand.
It's a real state.
We fully understand. As I said, we don't expect 100% adherence. And when we look at page 29, and you can see the different variation, we are looking into to include nurse visits and home nurse visits. Is that correct as part of this, or is that so? We want to make sure that the child is at least being assessed somewhere in the system. But you can see that there are some folks doing a better job of this than others. And as we said earlier, to qualify for gain sharing, we would hope that people would at least be in the pack and not out of the pack. So given your caveats about the realities of dealing with the general public, there are still, you still can accomplish a certain level of impact in terms of achieving follow-up visit rates. So we don't want to have gain sharing go into folks who are on the outlier status of failing to get that done. We're not dinging everybody for an individual case. We're talking about your general performance over time. And yes, there are going to be things that you do the best you can, and there are folks that can't be helped. We understand.
If you look at the other episodes that have launched, there are many episodes that have metrics, quality metrics that have a big, or patient compliance is a big portion as well. COPD, asthma episodes, some of those are what's the rate of the patient seeing a PCP or a physician within 30 days post-discharge. There's some medication adherence stuff. And if you look historically where the payers have set the threshold to qualify for gain sharing, it is not anywhere near 100% because of the historical curves. It's substantially lower. All the numbers are outlined someplace for each of those past episodes. I think there's a question in the back here.
Question about evaluating some of these rates. What time period or denominator are you using? I mean, how are you going to compare small hospitals to larger ones? And, you know, one CLABSI in a small hospital is going to send your rate way up. So how do you over multiple years?
It's a great question. Bill, you want to describe how you guys have approached this?
Well, first of all, CLABSI is for information only. So it's not. There are only 3 that are involved with thresholds for gain sharing. So it's really for feedback. And it'll give us a sense of just where people are, and you can compare yourself to others. So again, some of it's feedback, some of it, the accountability ones, if you go back to page 27, well, there are only 3. One is the BPD rate, the report, metabolic screening and hearing rate, and most institutions are doing very well on that with a few outliers. And that's something you can control. And then the 7-day follow-up rate, and again, we're looking, as we've talked about, at least to be in the pack and not be an outlier. Would you want to comment on the BPD rate as part of as an accountability measure?
Sure. Remember, this is 29 to 34 weeks, so the BPD rate is actually going to be pretty low in that group of patients. The other thing we've talked about is possibly adjusting for prolonged rupture, such as rupture before 18 weeks or before 2 weeks prior to delivery. So both of those things we know clearly relate to BPD, so those can be adjusted for. And we don't have to worry about adjusting for the real tiny babies because there's a high frequency of that. The other thing that we just to mention, Bill, I think you raise it to validate your point. You make a very good point about that. Our thought was in the group that even though, yes, there are going to be some patients that will not do it, of course, we don't have any patients like you're describing at the medical center. But if we did, we would hope that our ways of involving social work and doing all the things that all of us do would make things even out in the end. So that your point's well taken, but we think that we are doing something that will call resources to do that.
If you have something like BPD that has a low incidence in a small hospital, you're going to need more time potentially to really get good data points.
Thank you. Dick?
I think it's the word rate and how that's going to be calculated with a low volume versus a higher volume. I think the word rate is what's concerning Christy.
I think that's something that the payers have not, in some of the other episodes where there have been similar things with some of the smaller volume cases, in some cases the payers ended up going with a rate with a more lenient threshold for that. In some cases they went with an absolute case volume. I don't think that's been decided yet.
But you're going to be compared against the same level nursery, correct? I mean, when you benchmark this, you're level 4, you're going to have to find benchmark somewhere nationally. Level 3 can be in the state, 2 in the state. Is that?
Well, we can look at it and we can chat with Wittes as well. When we did a thing on PCIs, we looked at a portfolio of complications, which are unusual events. So rather than a rate, because the rate would vary depending on your denominator, we said, okay, you can have 2 of these, but you can't have more than 2. It doesn't matter if you're a big guy or a little guy. It actually puts the big guy at somewhat of a disadvantage. But these are rare events anyway. So, you want to talk about, we could talk about if you have more than 2 events, whether you're a big person or a big group or a little group, it's still an issue. So you want to make a comment on just the frequency and the avoidability of it?
Yeah, I think that, first of all, most of the hospitals that we're talking about will have adequate volume taking care of this group of patients. There's no hospital really that I know of, possibly with one exception, that is going to be taking care of most of the patients that might have BPD or might have collapsing, that would not have adequate volume to assess. In other words, about 50 patients per year or something in that neighborhood. So I would feel comfortable, at least in our particular state, with that. If they're a real small volume hospital, if they're that small a volume.
I think from the questions that I'm hearing and from the fact that your original statement was this is something that no one else has successfully ever implemented, but we are willing to try it and are trying. I think if the confidence level of trust for everybody in this room and everybody that's not in this room would be, if this is a continual learning experience for which we are going to always be looking for fairness with adjustments, I think a lot of these questions really just await first rollout to see where everyone is. It's a learning experience.
Yeah, we've always said all this episodes of Care Stuff, we're version 1.0. We're learning as we're going. We wouldn't be having these sessions if we didn't believe in that, because this is part of the process. So, I think I think the clinical advisory group thinks that we're on the right track, and it's close enough to consider rolling out, to be putting out, to give you this feedback. But again, we can make adjustments as we move forward.
Are the ventilator days the tracheal tube or RAM, or are we defining that?
We're
Ventilator days?
We're following up on that to most
Okay.
likely be consistent with, again, the Vaughan definition of
Intubate.
ventilator. Yeah.
Okay.
But that's something that hasn't been finalized yet.
Just instituted pulse ox screening for congenital heart disease. That is definitely linked to better outcomes. As you let some of these babies go too long, you're going to end up with a massive hospital bill. I would just consider that since the legislature passed it and we're now joining those states, I think pulse ox screening, find a congenital heart lesion earlier, it's going to have a better outcome, more likely to have a better outcome, and it won't cost as much.
And is that something that should be happening across I'm hearing yes, across the board, that should be as high as possible, that number, for all neonatal segments? No?
It should be happening at the same time as the metabolic screening.
So the hearing and the
Yeah.
I guess my question is, if you look at the population of neonates, should that be, basically, should all neonates be getting a pulse ox? Or I hear yes from here, but I hear disagreement over here.
Yes, for the term baby, but who's going home at less than 7 days. But if for a preemie who's in the hospital for a long time, it's not a metric. So, it depends on the patient.
So I heard pulse ox screening as a potential metric, and I heard over here that not necessarily for every baby. And this may be something we take offline too, but I think it's a good.
Yeah, I agree with her. It fits in with the newborn screening that we do across the board. But yeah, there's going to be exceptions where it doesn't make sense.
So maybe this is something we can follow up with you guys with right after the session here. Thank you. So that was a good. Any other quality metrics? No. Okay, great. Let's move on then. We walked through. Bill described page 29. Actually, on page 28, you can just see for Medicaid and for Blue Cross the rate for three select metrics: the hearing screening rate, 88% for Medicaid, 84% for Blue Cross neonates; the 7-day follow-up rate, 67% and 72%. Again, this does not yet include some of the pediatric home health, but 67 and 72 for physician office visits, and very low rates of neck. Page 29, as Bill walked through, was the variation across facilities for the 7-day follow-up rate. And page 30 also has the variation across facilities for the hearing screening rate. You can see, as Bill mentioned, the majority of facilities here are 90% or above, thereabouts, on the hearing screening rate, with a smaller subset of providers that have a much lower rate.